Focal spikes are so difficult to identify sometimes. And you see only in talks the easy ones, but not the more difficult ones. And certainly the waveforms are sharply contoured to start with. That's number one. But there's a lot of background waveforms which are sharply contoured. So therefore, these spikes have to be distinct from the background activity. And they must interrupt the background activity. And you will find that they have more than one phase. In other words, they might go down a little, then up, and then down, and then after. So not just going one direction. The largest phase of most spikes is usually electronegative, except for some spikes in children. They have asymmetrical slopes a little bit, like that, or like that, but this is more important, the fact that the largest phase is electronegative, and you'll see that in many times. Spikes, even though they come from one area, probably involve more than one electrode position. So if you see a great big spike looking like that, and it's only one electrode position, you better think of artifact, and that's why we used that, had that artifact lecture before. Spikes are almost always followed by a slow wave because the spike is excitatory, right? It reflects some excessive excitation in the brain. Someday we might do a talk on what that really respects. But to stop that excitation from becoming a seizure, you have to have inhibition, and that's what's represented by the slow wave. So those are some characteristics of spikes. Next, please. So, no, I guess go the other way. Yeah. So in the temporal lobe, these spikes in the temporal lobe have some special characteristics. They're electronegative like anything. Now, they involve principally the mandibular notch area, and that is right here underneath the zygomatic arch. If you touch your own face, you'll see you have in the zygomatic arch here, and then right underneath it, that's where we put the mandibular notch electrode, and we put it right on the surface of the skin. We don't put anything in the nose sphenoidal here. And it involves T1, M1. T1 is just above the mandibular notch. You'll see this very well in a few minutes. And F7 and A1 and T3. These electrode positions, okay? And T3 being left mid-temporal. Sometimes you see involvement of the other side as well. And sometimes you'll see spread to the frontal polar region, and that can be a very, frontal polar being up here. That can be a very difficult problem. Next problem, next please. So they're a sharply defined field. They have steep voltage gradients sometimes. Now if you look very carefully at these spikes, a whole series of them, you'll see that they're not exactly stereotyped. They're almost always little variations from one spike to another. Why is that? And that is because when you think of temporal lobe epilepsy, as I want to emphasize before, it's more than one zone in the temporal lobe involved. They're very narrowly separate, very narrowly separate. And that was first shown actually in depth recording by a fellow named Lieb, who worked with Engel in Los Angeles. And when they put in depth electrodes in the temporal lobes, which they did in every patient way back in the 1970s, they don't do that anymore. But when they did, and when they found only one area of spikes in the temporal lobe, that wasn't the side of most of the seizures. When they saw several areas just right, very close to each other, having interictal spikes, that was the area of epileptogenesis. And you remember earlier today when I showed some of those temporal lobe seizures, and I was showing you that actually during a temporal lobe seizure you have actually lots of, at least 2 or 3 different seizures going on at the same time. It looks like one, but if you look very carefully, you'll see different rhythms, you know. Same thing with the spikes. There might, in between seizures, there might be variety in the field. So a lot of times in the temporal spikes, there's going to be more than just spikes. There are going to be other abnormalities, and I'll show you an excellent example of that later. Next, please. So it's too bad that I didn't put this later, but it doesn't matter. They're also electronegative. They're present with the eyes closed, and they're in the back there. And you may need an ECG monitor to show the difference. Next, please. So here's the temporal spikes. And I'm not showing everything. Most of my slides, I don't include the whole EEG. I just show the EEG that is important here. And so here, we'll start with this one, FP1, F7, F7, T3, T3, T5, T501. So frontal polar to the inferior frontal, which picks up the anterior temporal, the anterior temporal to the mid-temporal, mid-temporal to posterior temporal to occipital. Now, it's quite easy to forget this right now. Just pretend it's not there. We just concentrate on these four here. And notice how interesting the phase reversals are. But notice how that spike location, you see you have this down, down, and up. That's actually phase reversing at T3 at that point. But notice this one doesn't do that, right? Two temporal spikes, one next to the other, and this one is canceling between F7 and T3, okay? So this one is a little further anterior than that one is. And you can, so you see these slight variations. Now notice another thing. Notice that if you do the coronal montage, going from CZ down through to the other CZ, and you see the right side isn't involved at all here, but you see how much M1, the left mandibular notch, is involved here. And notice the little variability here. This is going down and this is going up. There's just a slight variability between that and that, and quite a bit of variability between this one, and then this one and that one, for example. Okay? So they're all temporal spikes, but they're not all the same. And the mandibular notch electrode is heavily involved. You can see that because it cancels with T3, T3 definitely involved. And notice if M2 you can see is not involved at all. So M1 going up to M2, and you can see the very considerable involvement of the mandibular notch electrode. Next, please. And this is the exact same thing on the other side now. You can see M2 and T4 in another patient here. And again, you see this variability. There's a temporal spike, there's a temporal spike, but they don't have exactly the same field. Eh? These coronal montages this is a very useful montage, because sometimes you don't see things that well on the anterior posterior. Notice another thing here is that usually there is some sort of cancellation and a simpler way, sort of a complex morphology here at F8, T4. Why is that? Because the spike involves both F8 and T4, and they're kind of fighting each other for prominence. You can see that the whole arrangement is simpler when you go FP2 to F8. F8 is negative, and then T4 to T6. T4 is negative, and then T4, F8, T4 will have sort of an intermediate kind of a morphology. Here's an excellent example. F8 is negative, T4 is negative, and then this thing is going up and down. It has more phases because the field is very complicated in this area as the spike evolves, you see. And again, this is an unusual number of spikes, of course. Usually you go a long ways in the EEG before you see this. But I emphasize that this montage is a very useful montage, this coronal run here. This even here, F7, F8 is not bad. As you can see, F8 here being much more involved than F7. So there's value in even that. So this is a good montage. Next, please. The average reference is called the common average reference. And if you're sure that you have a very focal abnormality, the average reference is good. Okay? But if you have a widely diffuse abnormality, it will contaminate the average reference. Because the average reference common average reference takes all the electrical activity of the brain at that point and adds it all together and puts it through a high resistor, and that creates the reference. And if you have a widespread abnormality, like in a spike and wave or something like that, it will contribute to the potentials picked up as the average reference, and therefore you will get a very complicated thing because you won't know whether what you see is coming from input 1 or input 2. But when the discharge is very focal, as it is here, then you're very, very certain that that this is really that input 1 is creating this waveform and not input 2. So you can see this discharge here at in this case right temporal, very frequent. And once again, you notice how variable is the morphology, which represents a slightly variation in field. So this is at M2, T4, F8, right? Not so much T6. So these are right anterior mesial temporal. So next, please. And this is Gibbs's picture created in the 1940s based on his field plots of temporal lobe epilepsies in his 8-channel paper EEG, and this is what he came up with. Now you remember the 1020 system popularized and created by Herbert Jasper in 1958. You know, that's FP2 there, and this is F8 right about here. Why does F8, which is frontal, inferior frontal, why does it pick up temporal lobe abnormalities? As often your dipole is going in this direction here, and one end of the dipole, therefore, is seen by the inferior temporal. And this is T4, T6, and O2. Notice that the whole 1020 system passes slightly above this field, and that's why you need that M2 electrode, and that's where M2 is, right here, okay? And the same, so that's for anterior mesial temporal spikes. That's what their field is. Now, if these were not mesial temporal spikes, but convexity temporal spikes, you'd see a be more a little higher voltage, more high placed. Notice how close around the eye these spikes become, and sometimes they can even propagate from here all the way to the frontal polar region through the uncinate fasciculus. You remember the uncinate fasciculus in medical school went from the mesial temporal to the orbital frontal area, and so sometimes that can be confusing. Next, please. Now, I told you a few slides back that there's more to temporal lobe epilepsy EEG than spikes. So this is the right temporal, and this is the left temporal. And if you look carefully, you know, now I know there's some perturbation here, some slow waves for some reason or other, but this is basically normal EEG there on the right side. But notice the slow waves on the left. You see those? Forget this for now. Just look at the slow waves. See, there's more slow waves here on the left side at F7T3 than there is on the right side at F8T4. Right? Everybody see that? Yeah. And that's sometimes the only thing you're going to see on outpatient EEGs. You won't always see the nice spike. Again, notice how often anterior temporal spikes tend to cancel at F7T3, they both being involved there. Next, please. And this is a bit later, I think, on the same part. This is the reason I show this is sometimes things are, you know, you could miss things like this if you weren't careful. The patient just decided to have a lot of eye movements here, and that makes it not look so hot, and there's the spikes coming through the eye movements, you see. You would have seen it better maybe if you had an M1 electrode there. So, next. And the same thing on the right, eh? We've seen that. And then, again, further emphasize sleep recordings, and notice how you get, again, this cancellation between the left mid-temporal and M1. Eh? In other words, here. So, next, please. Now, don't forget to use sometimes coronal montages going across. Remember when I was going through the principles of of polarity, I showed that spike at, in the coronal montage. Coronal montage is very good because sometimes the fact that F7 and T3 can be equally involved, they can cancel each other, and sometimes you won't see the spike very well, and you'll need a coronal montage to show this clearly, you see. And you can see that F3 is a little bit negative next to FZ, but F7 is so much more negative than F3. Same thing here, C3 is slightly negative, but this isn't a left central spike because T3 is so much more negative. It goes way up to the negative C3. It's very negative. And notice that it's seen principally this spike primarily at T3 and F7 with slight spread to T5. And then always, whenever you design a montage, a bipolar montage, you should try to have each electrode positioned in at least 2 places on the montage. So F7, F7, F3, F3, P4, P4, T5, T5. There's an exception here, A1, A2, you don't see it the second time. No montage is perfect, but that's, you need that repetition, okay? So, yeah. Anyway, oh, and then you notice the difference between the ECG here and the spike. You know? Next, please. Well, we've practically seen that already. Next. No, we're going. Are we going the wrong way? Okay. Now, notice that even in the elderly, you can see focal air abnormalities. This woman is 76 years old. And in the elderly, you have to remember that some elderly will normally have some slow waves in the temporal lobe, okay? I mean, so this right temporal lobe has slow waves in it, but at age 76, that's maybe not too bad. That's all right. But this isn't normal for any age, right? This delta activity, and notice the spikes in there as well, okay? So next, please. Now, I mentioned small, sharp spikes. I'll just say the same things all over again. Small, sharp spikes, you just have to get to know them by their morphology. They look like that. They're much quicker than the abnormal anterior temporal spikes. That's one aspect. And the second thing is these are normal phenomenon, but they're very widespread. You see how many channels will express them at some point. See that? Look at that. It's about a little over 50% of the channels because they have such a huge field. And these are seen almost exclusively in sleep, have that kind of morphology, and you'll get used to them eventually. But it can be a problem distinguishing those from anterior temporal spikes. Now, one thing, what we always try to do in EEG is if you think you have to kind of prove to yourself that you have 2 different kinds of phenomena here. Anterior temporal spikes maybe in some patients, and then small sharp spikes as well, okay? Don't try to, if you're not sure, call it one thing, okay? Either anterior temporal spikes or small sharp. Don't try to guess on those things, though. But these can be quite abundant, exclusively in sleep, and they have a widespread field. This is about the most characteristic right here, see? It's present in most, you wouldn't see that on an anterior temporal spike. Next, please. And now, just to show, though, that this isn't all that easy, here's some temporal spikes that look a little bit like small, sharp spikes, but still that, and they have a bit of a wide field as well, but it's really all unilateral here at F. And this is another good montage, actually, is CZ for temporal lobe, because it's far away from the temporal lobe. And so using a CZ montage can be very helpful. Next, please. Well, it's just more of the same, isn't it? This time it's M2, you know, and slow waves along with it. That's almost always. When you see temporal spikes, you'll see slow waves at the same time. Next, please. Now, this is a seizure. And the seizure, we described this, Brian Young and the late John Lemieux and I studied the morphology of electrographic seizures in 1984. We published this. This is 22 years ago now. And we found that one thing that characterized electrographic seizures from normal phenomenon was an evolution in their in the morphology. So this is not a right temporal seizure. So what's happening over here is only just secondary to the left. So concentrate on here. So what you have is FP1, F7, F7, T3, T3, T5. Not a very good looking spike, and maybe not even a spike. But anyway, suddenly you go from this kind of activity to this kind of activity. So something new that could not be explained by a change in state. So there's a change in the EEG. But then there's a change in the change. So you go from one thing to a second thing to a third thing, okay? So it's progressively evolving. You see that, eh? Next, please. Same seizure. Notice it's got even a third morphology here, and now a fourth morphology. See? So it continues to evolve. And we found that focal seizures in adults or children they evolve in about 98% of cases. And you can see that we're going from very rhythmic waves here to slower sequential spikes as inhibition starts getting in there. Notice the involvement of the other side. Finally gets over to the contralateral temporal lobe. Next, please. And then as the patient, as the seizure is progressing and inhibition is beginning to really take over now, you get a spike and then a wave, and a spike and a wave, a spike and a wave. And these waves indicate that inhibitory postsynaptic potentials are becoming more and more prominent as the seizure begins to. Notice the seizure move back a little bit. T3 cancels with T5 here toward the end. And note the moderate involvement of the contralateral right temporal lobe toward the end. And you notice that this represents chewing or swallowing. Patients with, automatisms usually don't start at the beginning of a seizure. Automatisms of chewing or fumbling with the hands take a few seconds before they're manifested in a seizure. So next, please. And then at the end of the seizure, you see the right temporal lobe really almost normal there, whereas the left temporal lobe here has this delta activity. Now, Masako Kaibara and myself studied the postictal EEG, and we found, to our astonishment, that way over 95% of the time, the postictal EEG localized the onset of the seizure. In other words, if you're suddenly looking at an EEG with delta activity on it like that, and you miss the beginning and the middle or the whole seizure itself, and that's all you see, that's not very good. It's much better to have the seizure. But this gives about 9 chances out of 10, or more than that actually, that it's localizing to the onset. Okay. By the way, if you're reading an EEG, outpatient department, and you see a delta looking like this, which gradually disappears, you know what happened. The patient had a seizure while the technologist was preparing the EEG, okay? And maybe the technologist didn't notice that the patient was sitting there going, or something like that. Eh? So if you ever see a delta activity while you're reading an EEG that gradually disappears, that's probably a postictal delta. It's not a transient ischemic attack or something. Next, please. Now, again, this is going here in the right temporal and the right temporal. Notice that it really doesn't evolve. I mean, this is a little higher voltage than that, but it doesn't evolve. It doesn't evolve. Next, please. And it keeps, well, now it does evolve a little bit. Yeah, I can't say it doesn't. Then it suddenly stops. Well, this patient was just jerking one arm or one leg during the thing, trying to have a pseudo-seizure. This is not a seizure. Not a seizure. This isn't the way seizures look. So always, when you see lack of convincing evolution during the seizure, wonder if it's something else. And this patient was just feigning a seizure with moving an arm to create the artifact on the EEG. Next, please. Now, these are not temporal lobe spikes. Notice that they're very distinctly not. So we have left parasagittal, right temporal. And notice that these are electronegative at F4. F4 is electronegative, goes up to C4, but FP2 is even more negative than F4. So these are right frontal polar spikes, okay? And you can see they're spread here. And they don't involve the temporal lobe at all, really. I mean, you're a little spread maybe to F8, but that's also a frontal electrode. So these are right frontal polar spikes. The curious thing about them is that usually frontal polar spikes are seen much better over at the contralateral FP1. In this case, you don't see it very much. You see it just a little bit. Usually it's quite more. But notice one other thing, and this is not easy, is that there's delta activity behind those spikes. See that? Forget the spikes for a minute. Just look at the slow waves and the slow waves. Now, the hard part is that there's always a tendency to have a little bit of delta activity in the frontal polar region all the time because of random eye movements. But you can see that this delta here is distinctly more prominent than it is on the other side, indicating it's probably not eye movements. Okay? If you don't know and you can't figure it out, what you should do is put electrodes underneath the eyes here and refer them up to CZ. An eye movement will phase reverse. If the eye goes up, it'll be going toward this electrode and away from this electrode, right, etc. And you can distinguish delta activity from eye movements that way. Anyway, this is about the best example of frontal polar spikes you'll ever see, because most of them are not this easy to localize, I'll tell you. Next, please. The other thing I showed you the other day, yesterday, was these little things here that look like little muscle potentials from small eye movements. And that's true. Most of the time, these are. But be very careful, because notice what happens here. These look just like what I showed you as being from artifact around the periocular muscles, you know. But then they keep coming, and they keep coming, and they keep coming. And look at this. It gets more and more, and they more spread. And what's the difference between this section and this? This patient is more drowsy and so those spikes just got more and more prominent. So don't ignore those little things, because they could become real spikes later on. These look just like artifact. Exactly. You couldn't call that, for example, a spike. That you'd even have difficulty calling. Maybe that. This is easy here, you see. So don't make up your mind too rapidly about whether sharp frontal polar things are eye movements or whether they are spike discharges. Next, please. Now here's an interesting montage, and this is a very useful montage to tell the difference between frontal and temporal spikes. And you start at A1, the left ear to the left inferior frontal. Left inferior frontal, left frontal polar. Left frontal polar, right frontal polar, right frontal polar, right inferior frontal. And you can see where the phase reversals are. These are not temporal spikes. This is very sharply reversing phase right at FP2, right frontal polar there. So this is a very good, a temporal spike would be down and then further down and then maybe canceling between F8 and A2. A2, the right ear, often picks up very similar potentials to the right mandibular notch electrode. This is the ECG down here. Sometimes, whoa, wait a minute. Hey, wait. Ah, that's a toughie. How much of that's ECG? Maybe that is, and maybe that is. Some of those might be these spikes. I guess they're not, though. That's close, eh? It'd be better to just have an ECG lead here. But you can see the value, though, of this coronal montage to show when things are in the frontal polar region as opposed to the temporal region. So, and notice F4, F8 enter, you know, you hardly see any spikes here. You see them, they're really right frontal polar. Okay, next, please. Now this is, we're going from the front of the head now to the back of the head, and this is probably a child, but I on purpose didn't put up the age up here. And this is a sleep recording, and you notice there's lots of things to notice here in this sleep recording. First of all, the V waves are pretty symmetrical. They're not very good looking V waves. They're kind of broad, This is a bit of a broad V wave. Usually they're much narrower and sharper contoured than this. Whether that's an abnormality or just a curiosity, I'm not sure. Notice the spindles here at F3 and C3, not at F4, not at C4, and in this patient that was consistent. The spindles were reduced on the right side. Now, the only thing there's a couple of things that could increase spindle voltage, and that's a skull defect if somebody operated on the left frontal region, but that's uncommon. There's a little thing called extreme spindles, which the patient doesn't have. Extreme spindles are spindles that never stop. So these are really normal spindles on the left, not on the right. Normal on the left, not on the right. And always be looking for that when you're reading sleep recordings, because it lateralizes things pretty well. Now, you notice that that's not the only thing the patient has on the right hemisphere, though. Instead, more than just a decrease in the sleep spindles, you notice these spikes here at O2. And notice also that as opposed to that boy that I showed you yesterday that was kicking, every time you see a spike here, you see a little bit of involvement in the parietal lobe. See that? Each time, and also on the left occipital lobe as well. So these are the behavior of right occipital spikes. Now, some people say that occipital spikes do not lateralize which occipital lobe contains the seizures. And I say that's because they didn't look hard enough. And we looked hard at this and found that the side of occipital spikes is very localizing to the side which occipital lobe has the seizures. Next, please. And this is not a bad montage, actually. It's not the best. I think the other one's a little bit better, but you know, you have to like all montages. You never know when you're going to need them. This is going from F7 all the way through to F8 here. So this section of the montage is here. And you can see everything is okay, until you get to here, O1, O2. And you can see that O1 goes downwards to O2. O2 is negative to O1, right? And then there's this cancellation between O2 and T6. And you can see that T6 goes up to T4 because T6 is negative. So that you have a negative spike field involving O2 and T6. Now, T6 is technically posterior temporal. Yeah, it is. But patients with anterior mesial occipital spike discharges, I noticed that they'll go out to T6. Okay, the anterior part of the calcarine cortex will go out to T6. So this cancellation is not a surprise when you're dealing with occipital seizures. You can see them here in this referential recording, O1 to the left ear, O2 to the right ear, and you don't really, and his is very interesting actually because there's an awful lot of sharply contoured waves in the background activity, but then you can see these as independently occurring right occipital spikes. But you could argue that the bipolar is a lot better. And then you can also see them there. And now we do have an ECG to show that the spikes are not the ECG. Got to have that. So you don't want to be too rigid about what montages do the best job because you never know which one is going to help most. Next, please. Now, occipital spikes can look like artifact. And a technologist running a recording may think that he or she has not applied the occipital electrodes properly, or maybe that the patient lying on his back and they didn't put a pillow underneath the neck to get the head off the back of the chair or the back of the bed that they're lying on. But that's what occipital spikes can look like in sleep. This is sleep recording with all this delta and V waves and things. But notice these spikes here. And notice that there are multiple spikes or polyspikes here. And they're really not artifact because you can see them just a little bit there up at P3 from O1. And you can see them even better at T5. Here they are at T5 going down to O1. O1 is very negative here, but you can see they do spread a little bit up to T5, as I said before, for the other ones. But notice how they look sometimes like muscle potentials or artifact, and notice how abundant they are once you realize what they are. Next, please. And that's our boy kicking. I think I've shown you that 2 times already, so we won't do it again, except to show, again, huge discharges here from kicking at O2, no spread at all to P4, which, doesn't happen. Next. And there's another example of the same spikes I was showing you before, practically, and how varying in their morphology and how often in sleep they can have polyspikes in the same, in a burst. Next, please. And you can see it again on a referential montage to the right ear. By the way, how do you check to see whether the reference is good or not? How do you know? How do you know that this comes from O2 and not from A2? Well, what you do is you check some place that's way far away from O2. You go up here, okay? So if you see any spikes at FP2A2, unless you really have some concern from other montages that it could be up here, but if it isn't, and you don't see any spikes here, you know that before you started that there weren't any here. If there are no spikes, then you know there's none here. If there's none there, then you know that this is all from A2. That's how you check your reference out. Next, please. Oh, this isn't going to do very well. Oh, la la. Anyway, it looks like EEG in a fog, but I think we can maintain the principles anyway. This is subdural EEG. Subdural EEG, and this is background activity. And I think you can see that a seizure is starting here. Nothing happening over here at all. Next, please. And this is a very focal right lateral occipital seizure, 2 electrodes in that area here. And then finally, it propagated to the left mesial occipital region. Why it did that, we don't know. But notice the seizure continues here, and then a new seizure starts in the left mesial occipital region, exactly as I showed you earlier today in another one. In other words, 2 seizures going on simultaneously. This one probably depended upon this one. Next. And this is going to get worse instead of getting better, but you can see that this is beginning to slow down now, and this has spread now to the right anterior temporal region, and it's having its own seizure. So you have 1, 2, 3 seizures all happening simultaneously here as the left mesial occipital really gets going. Next, please. And I really apologize for the terrible quality, but this seizure now has ceased, has stopped in the right lateral occipital region where it started, and is going very, very prominently in the right anterior temporal lobe, and now also in the left anterior temporal lobe and the left lateral occipital lobe. Next, please. And these are old slides from biomedical systems way back when we had it, and all our slides looked like this years ago. But this is just another example of very, very prominent occipital. But I wanted to point out in that previous how commonly occipital seizures spread to the temporal lobe. So when you have somebody with temporal lobe symptoms, always make sure you ask them if there's any visual change that preceded it, okay, like flashing lights in one visual field. And when you examine the patient, you want to make sure that this patient doesn't have a visual field defect. You have somebody with a temporal lobe epilepsy, you should always examine the visual fields, because you know that the symptoms may represent involvement of the temporal lobe, but that's only involvement. Maybe it didn't start there. Maybe it started back in the occipital lobe. Now, why is this such a big deal? Because the temporal lobe evolved in the same manner at the same time in mammals as did the visual system in mammals. So the two went together. And the temporal lobe is a synthesizer of your activity, but primarily it's a visual lobe. The two went together. That's why in temporal lobe epilepsy, most of those experiential phenomena are visual. They're not auditory so much, they're not somatosensory so much, they're visual, because the temporal lobe is very much a visual system. So so there's a lot of fibers going from the occipital lobe to the temporal lobe, and so therefore when you have temporal lobe epilepsy, you always think, could this have originated more posteriorly? It's uncommon. I mean, more commonly, it'll just be temporal lobe originating, but that should go through your mind. Okay, next, please. Here's another one. I think this looks a little bit better. Another seizure, just by repetition only. This is the left let's see. Yeah, this is the left temporal, and then this is the right temporal. And there's not much happening on the left side, but here you see right around here, you have a brand new phenomenon as sequential spike discharges, which cancel between the negative T6 and the negative O2. You can see T4 going down to C6. T6 is negative, and then the negative T6 is basically canceling with the negative O2. And you can see how this evolves a little bit now, and now you have an evolution just like seizures. They always evolve, not involve, evolve. In other words, they change. Actually, there's a third phenomenon here. So you have this morphology, and this morphology, an evolution, a change of a change of a change, basically. Next, please. And you can see as this keeps going, on we go, and it goes over to the left side, okay? And so you have these sequential spike discharges here, principally at O2, spreading to T6, and also at O1. So that's a good right occipital seizure spreading to the left. You see how often patients with occipital epilepsies, they will complain of a visual phenomena that's in both visual fields. And if you ask them, well, where did it start? They say it started everywhere at once. And actually that is as common as a unilateral visual field change. Ipsilateral, very, very rare situation. So you either get contralateral visual field abnormalities like flashing lights, or bilateral, even though, and the bilateral can still represent unilateral occipital epilepsy. Next, please. Here's another one. 14-year-old guy. Now this has historical significance. This was way back in the days of paper, and so the reproduction is terrible. But the only point of this seizure is to show how long it took to get to really identify itself. So 14 years. Next, please. 35 seconds later before he ever really got going in a seizure. Next, please. 100 seconds later, finally he's still getting the seizure going. It's amazing how long those things last. And keep going, please. And you know. Now, here is my tennis coach. His EEG. And my tennis coach has a lesion in the left posterior temporal occipital region. And he is, his seizures can be maximized when he's looking at a tennis ball moving across the court on several rallies. And if a rally is too long, he'll have a seizure. Now, it's interesting that he underlines very clearly the principle that occipital spikes are present with the eyes closed. Eyes closed. Notice he's alert, he's talking, and he's having occipital spikes. As soon as he opens his eyes, spikes go away. And that's so typical of occipital spikes. Eyes closed and sleep, but not eyes open. Eyes open will stop most occipital spikes right like that. You know, so next, please. Now we go to Rolandic spikes, and it's the only one I think you've seen already, and that has a dipole. In other words, you see that F4 actually is positive, and C4 and P4 are negative, and these things are so typical of that. And we were reminded that this may have some significance for attention deficit disorder, ADHD, which is something I just learned an hour or so ago. Next, please. And we've been already through the complex field of these spikes. They look like they're anterior temporal with negativity at F8 and T4. And then, but I showed that actually this downward deflection reflects positivity at F4. And you can see the slight hint of that on this bipolar montage. Next, please. And you remember we said that if it really were from F8, you should see a huge deflection at F7, F8, and you do not, and that was the first clue that, that this was not so much involving F8. Next, please. And in fact, you remember I showed you that, yes, they were involved at T4 being electronegative at their peak, but then simultaneously you had electropositivity in FP2 and F4 to account for this crazy dipole. This, by the way, it looks like a temporal spike, and it is in this little section here. But if you see this, you know it's not an anterior temporal spike, because anterior temporal spikes are seen prominently in FP2 to F8, because F8 gets very heavily involved, and there's usually some cancellation between F8 and T4, and then T4 deflects very prominently with the relatively uninvolved T6. Whereas in this circumstance, this is primarily in the neocortical part of the temporal lobe, clearly phase reversing without any hesitation whatsoever at T4. You can see the difference between that and the anterior mesial temporal spikes I showed you several minutes ago. Next, please. Now, these are another example of abundance of children's spikes. This is a child. Adults don't do this so much. Very abundant P3 spikes, very, very focal here, spreading a little bit to C3. And in children, sometimes the quantity of spikes do not represent the severity of the epilepsy. It's a paradox. Focal spikes, I mean, focal. Next, please. And another example in children of abundant spikes. So you really can't give bad news to the parents just because spikes are very frequent in children. Next, please, in focal spikes. And I already told you that during arousal, when you're preoccupied with the diffuse changes, don't miss the little small things in life. Little things mean a lot sometimes, so don't be overwhelmed by the diffuse. Always look for the focal within it. Next, please. Okay, and we've been through that. Let's go ahead, please. Okay. Oh, there's a couple of interesting situations here. This patient, I forget why this patient is in the intensive care unit, but I just wanted to point out one thing here, and that is, notice the left parasagittal region and the right parasagittal region, okay, and then the left temporal and the right temporal. Now, notice that this beta activity is medication-induced. Notice it's present on the right, but there's far less beta activity on the right side as compared to the left, right? That's abnormality number one. Abnormality number two is the slow waves here, and you could say, well, that looks like an artifact to me at C4, and it could have been. However, if you keep recording before deciding that, and you see that these slow waves involve FP2, F4, therefore also F4. So you have a slow wave abnormality in here. Again, in the temporal lobe, temporal region, you can see that the beta activity is far more abundant on the relatively normal left hemisphere as compared to the right. It's a fair amount of beta activity there, but it's not as much as on the left side. Okay, next, please. And so then he very gradually starts having a seizure, and I'm not sure where that is. I think this is the beta activity of the interictal, but you can see that he's getting kind of drowsy here and is getting more delta, and I'm only showing the top half of the recording now. Okay, next, please. And now you can see that yes, he had beta activity here, and yes, he had beta activity on the right side. So more on the left than on the right. But notice this is a seizure, okay? And here, and it's also consisting of beta activity in the same frequency range approximately, looking very much like the interictal, but this is not normal for this patient's right side. He doesn't, interictally, he doesn't have this much high frequency activity. He has less here than in the left hemisphere, and suddenly, therefore, this is a seizure because it's a new phenomenon from where it is. Everybody see the difference then? Interictal, high frequency activity principally left, but ictally, you can see it here on the right. Next, please. And you can see this is continuing here, okay? You know, far too, and this is not muscle activity. If that were muscle activity, you wouldn't see these individual spikes quite so easily. This is just continuous spike activity spreading a little bit now over to the left side. You're seeing a more complex high frequency activity. You can see the beta activity in here, and then it's complicated by another beta rhythm coming in there. You can see how complex it's getting. Next, please. And it keeps going, you know, go back one, please. This keeps going here, becoming sequential spike discharges, you know. You know, even if you missed the beginning of the recording, here's how you teach yourself EEG. You read the EEG and suddenly you say, gee, something is happening here. What's going on? And you'd say, I guess it's a seizure. And then you'd go back and look at it at the beginning. That's how you teach yourself. You know. And notice that it's gone over here to the left frontal polar region a little. Next, please. And then notice how abruptly seizures stop. And I don't know why that is. Do you? I mean, seizures start so gradually, and then they stop, bang, just like that. You know, it's a funny physiology, I must say. And then we're back to the beta asymmetry we had here before. Next, please. So, okay. Now, Dr. Bakobashi, shall we go on to the generalized, or you want a break? We're almost done. Not too far. You've seen some of these slides before, but just to emphasize then some of the more specific aspects of them. We're going from focal now to generalized epileptiform phenomena. And the most common of these is generalized spike wave discharges with a repetition rate from 2.5 to 4 hertz. These bursts start and end abruptly. I've shown you that before. And don't forget, the repetition rate can slow as the thing goes on. Very importantly, the maximum amplitude of these is the left and right superior frontal regions. And sometimes they're more prominent in the left and right parietal regions. It's all in the associative cortices. Next, please. So sometimes these can go quite more posteriorly, but they have a variable extension. By the way, this term generalized is under some scrutiny in the English language. If you look up the term generalized in English, it means occupying most or much of the elements involved. So if I said to you that I generally get up early in the morning, you would note that maybe sometimes I don't, right? That's different than saying in English, I always get up early in the morning, which the older you get, the earlier you get up, actually. So generalized becomes always with age. But you see, the word generalized in English does not mean everything is involved, you know. It means that it's commonly involved, but not. So therefore, the word generalized does not mean that the spike waves are involving all the neurons in the brain. They're involving a good percentage of them, and it really means that there's bilateral involvement. That's probably the best way to say it. Now, our habit actually is to call things either generalized or focal. If you look carefully, the next time you see an EEG with spike wave discharges, look carefully, and you're going to see some that are regionally accentuated. In other words, just in part of the brain. Look very carefully and you'll see that. So therefore, incomplete forms of generalized spike waves occur commonly. And in sleep, spike waves are slower in repetition rate and they're not quite as regular. Next, please. So I showed you this before, and this is the easy one, right? Anybody can see that. 3 hertz spike waves starting very prominently and ending abruptly. Starting abruptly, ending abruptly. Notice that as the spike wave sequence keeps going, that the rate slows slightly toward the end. Notice that there are multiple spikes or polyspikes in the beginning and down to single spikes. Why is this? Is because excitation is predominant at the beginning, and as it keeps going, inhibition increasingly becomes more prominent to get the whole thing stopped. Next, please. And you can see this in sleep, that the spike waves are not as regularly repetitive here. They're disjointed, but they're still spike waves. It's just, and it's nothing wrong with the spike waves. It's just that sleep has distorted them. Next, please. And I've shown you this before, these 4 hertz spike waves that you see in juvenile myoclonic epilepsy. Sometimes patients with juvenile myoclonic epilepsy have absence attacks, and probably there is a tiny absence going there. This is 1 second in length, so this is about 3.5 to 4 seconds. Next, please. And then sometimes, as I've shown you all these slides before, but that's all right, see something twice. Notice that these are just rhythmic waves here. You couldn't call that a spiking wave, and each one of them probably individually would have a hard time calling a spiking wave, but putting them all together, I think you're pretty confident that this is a spiking wave. Notice that the spike of the spiking wave, the field, is a little bit smaller than the wave field. In other words, that spike is seen here and here and here and here and doesn't quite go backwards. The waves seem to go further or have a bigger field than do the spikes. Next, please. And I guess this is just a longer situation here with absence attack going on here. If you see this as an outpatient, you know that you haven't controlled the seizures no matter what the patient says. Next, please. And next, I think we can go ahead. So that's easy. Next, a little bit more difficult, the bursts of polyspikes. And I've shown you some of this before, but we'll just repeat it again quite quickly, that these go at about 10 to 25 hertz. And why are they going like that is because the cortex is just excited. The neurons are tonically depolarized during this period of time. And they can last for a while, as you can see there. And these are associated with tonic seizures or even absence. And they may occur on eye closure. Next, please. So there you have them, You know, looks like artifact, doesn't it? Almost look like muscle artifact. And this would be easy, wouldn't it? This might be a little bit more difficult. And this is what you have to start learning how to do, or perhaps you already know, is how to identify these polyspikes. And often, even if you didn't know these were polyspikes, you get the clue from the spike waves that will almost always occur during the same record eventually. Next, please. And as I showed this yesterday, I'll show it again. This combination of muscle activity and beta activity from medication, and then the polyspikes. So you have three types of very fast rhythms there. Next, please. And I showed you also these bursts of sobbing that look like spike waves. Why are they not spike waves? Because their field is far more widespread. Notice that. A spike wave wouldn't go all the way from the left and right occipital region all the way to the frontal polar. That just can't be. So therefore, you'd have to think maybe that these spike-like discharges are not coming from FP1, FP2, F3, F4, O1, O2. Maybe they're coming from A1 and A2. That's a possibility. How do you prove that? Change the montage to a reference montage, correction, a bipolar montage, and see if you still see them. That's what you can do now with digital EEG. Anyway, next, please. And photic stimulation is extremely valuable in patients with spike waves. As I said, it's a highly abnormal phenomenon to have a single flash rate elicit a spike wave. Always indicates a degenerative disorder without question. Next, please. Sometimes on bipolar recordings, these bisynchronous polyspike waves can be quite subtle. You see that? See how, you could miss some of these there. It's nice and easy to see on a slide, but in the actual performance in the day, you might miss them. And they are diffuse, aren't they? I mean, you see them a little bit. Mostly delta is the easier thing to see. A little higher right than left, but not necessarily focal. Next. Oh, can you go back one? Yeah. I mean, you could say, well, how do you know these aren't focal spikes? If these were focal spikes at F4, you wouldn't see any involvement of P3. You see, that's one of the ways to distinguish a regionally accentuated generalized discharge from a focal discharge. But I want to emphasize that this concept between focal and generalized, which we love to think about, is a little harder when you're dealing with nature, because nature sees everything as a continuum from 1 to 10 sort of thing. Next, please, then. Yeah, well, I don't think there's anything new there. Next, please. And then more, just a bath of polyspikes so that you can get that into your right hemisphere thinking. And if you have any trouble, you're always looking for that after coming slow wave there. Eh? That saves you. because if some kind of funny artifact probably wouldn't have that slow wave. That's what you look for, and then when you see that, you're more confident that these bursts are not some kind of muscle activity or some extraneous artifact. This can be difficult. It looks easy here, but when reading records, that can be difficult. Next, please. And notice, again, I showed you this before. No, it's okay to show it again, I think, in the photic stimulation. Notice how there's high frequency activity, which is not what I'm talking about. This is what I'm talking about. This is what I'm talking about. Same thing here, all on eye closure, okay? And don't forget, the lowest threshold of seeing generalized epileptiform potentials with photic stimulation is eye closure. The next lowest threshold is eyes closed, and then the highest threshold is eyes open. So it's safer to do photic stimulation. You start with low frequencies with the eyes open. And you tell the technologist if you get a lot of polyspike waves with the eyes open, no point in going on to eyes closed or eye closure, because you're liable to create a generalized tonic-clonic seizure. So next, please. This is a terrible slide, but I just want to show you once again that spike waves, the waves may be easy to find, but the spikes may be quite difficult. Notice how they're just in there. And this is an example of posteriorly accentuated, or they're only posterior actually, bilaterally synchronous O2 and O1 spike waves. That's not occipital epilepsy, that's just a posterior accentuation of what's essentially generalized epilepsy. Next, please. And there, notice how these can be elicited by passive eye closure, PEC. This is before passive eye closure to the left. You don't see anything when passive eye closure in this 2-year-old child and elicits these spike wave discharges, both O1, O2, bilaterally synchronous. Notice the muscle artifact there. Next, please. And then you can, sometimes that gets quite difficult. I don't know if you can see through the quality here, but notice everything to the left of these arrows is before eye closure. And there are really, there's a lot of beta activity in here, beta activity there, 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 there. But once the eyes close, you see that there are these polyspikes superimposed upon the beta activity. So beta activity, high frequency activity, close the eyes, and you see polyspikes with intermingled waves superimposed on the beta activity. So again, the value of varying ocular type of procedures when you're not sure whether there are polyspikes present or not. Next, please. So as I said, generalized seizures consist of bilaterally synchronous sequential spike waves or sequential spikes or rhythmic waves. So this, or that, or that. And the higher frequency phenomena usually appear earlier in the seizure than lower frequency ones. And usually there's an abrupt, non-focal onset and offset. No, non-focal. Next. Well, that's a terrible slide, so we won't show it. Next, the next one will be terrible too. Okay, let's continue. Yeah, that's a little bit better. And again, you know, that sudden onset and sudden offset there in an absence. Next, please. Yeah. Now, here's an interesting situation, and the quality is an old slide, but the message is clear, actually, though. And that is, this is what's going to become a generalized tonic-clonic seizure, as evidenced by all the muscle activity here, okay? However, if you see every time the patient's going to have a generalized tonic-clonic seizure that is preceded by spike wave discharges, which really is an absence attack, then you may, if you have trouble controlling these generalized tonic-clonic seizures, you might use a drug that'll stop absence, like Zerontin. And so this is one rare situation where Zerontin, which doesn't have any direct well, it's called ethosuximide as the chemical name, has no direct effect on generalized tonic-clonic seizures, but if you got this stopped, the absence stopped, maybe you wouldn't have the generalized tonic-clonic. So this is an absence attack becoming a generalized tonic-clonic seizure. Next, please. And here's another one. Now, this is a little bit harder to evaluate in this montage, which is a coronal montage, but you can see this is a generalized tonic seizure here, starting about here and ending about here with ongoing muscle artifact. But this is the tonic seizure here, right there. But you see how it's preceded by a very brief absence. Very brief, less than 1 second. Eh? You know, same idea. Okay, next, please. And I think I've shown you this, but I'll show it again. Is this poor lady who's now in her 50s, still having long absence attacks lasting about an hour or two. And here's her left parasagittal, right parasagittal EEG. Next, please. And then look the difference between that and the beginning of her unresponsive state. And she has these rhythmic waves. They look like a medication effect, don't they? But that's not what her background activity shows. So this is a new thing. Notice that these things evolve a little less quickly in the generalized than in the focal, but she's going on in this, and then next. And then as she gets a little bit more alert, she goes into spike wave discharges. So next, please. And well, I guess these are still polyspike discharges, aren't they? They almost look like artifact, don't they? But then there's that after-coming slow wave there. You know, next, please. And boy, these are terrible old slides. They're getting worse with time. Next, please. Yeah. I don't think there's anything brand new in here except the fact that if you don't know what you're dealing with in terms of the morphology and you're just trying to sort out morphology, use always an ipsilateral ear reference as is done here, and you'll see the morphology so much better. Again, notice the frontal accentuation of spike waves with some variable change to the back. Now, I'm not sure whether that's a spike wave or not, but when you see bursts like that, always keep recording for a while to see whether this eventually occurs. Next, please. And you can see, though, that if you do a recording long enough, you're going to see what you're looking for eventually, these bursts of high theta activity in here with intermingled spikes. Eh? And high theta activity with intermingled spikes. So anyway, next, please. And again, now here's an example, by the way, that the photically elicited polyspikes often have a morphology that's different than the spontaneously occurring spike waves. In this case, this photically elicited spikes are polyspikes, actually, and then followed by this absence with the... now, that can occur rarely in normal people, but the difference, we think, is that in normals, this would stop before the end of the photic, whereas in patients with seizures, it extends beyond the end of photic. Next, please. And if you have an old man who lives alone and comes in, looks like he has Alzheimer's disease or something like it, about 3 times in 10 years, it's not common, you're going to see this on an EEG. And the old man is not in Alzheimer's disease, he's in absence status. And why elderly people can suddenly go into absence status very rarely without a previous medication, seizure history is mysterious, but this is what you might see. So next, please. And I don't think we can, no, that's too poor quality, I'm sorry. And then I want to show you this again so that you get used to seeing it, these regularly repetitive rhythmic waves which could be misinterpreted as artifact or muscle activity, not muscle, but maybe medication effect, none of the same. This, always compare it with the background activity, which contains nothing like this, and this is this epileptic recruiting rhythm, and this is associated in virtually 100% of patients with seizure disorder, either seizures of the absence, they can have an absence attack looking exactly like this, or the tonic seizures. In this case, you can see that it's an absence attack because there's no muscle activity associated with it. So, and this is always, in my experience, therapy resistant, very difficult. So if you see this in an outpatient, somebody coming with absence, you should tell the parents that this may be difficult to treat. Next, please. Yeah, and here's another example, poorly done perhaps, but you can see that these polyspike discharges in sleep here. And sometimes you need a sleep recording to show how malignant the epilepsy actually is. So here's the sequential polyspike discharges starting suddenly, ending suddenly. And then if you go back and see some earlier examples of that, you can see that those polyspikes were minimally there, but you didn't dare identify them. They look too much like muscle artifact. And this also, same idea. When you see that, you could have difficulty controlling the seizures. Next, please. And the same thing there. You see it again, eh? Going from a awake patient this time, and although that looks like sleep to me, I'm not sure that's correct. That looks like spindles and then some V waves. But anyway, at this stage of the game, right from here to here, you can see sequential polyspikes, and then finally in a slow wave which ends it. Next, please. And sometimes you see these things in one hemisphere, right? I realize that child is only 8 months old, but the sequential rhythmic waves, the left hemisphere is wide awake. It's far too slow activity in this encephalopathic child, but you see these rhythmic waves only in one hemisphere. And that can happen. What can happen in 2 hemispheres can happen in a single hemisphere. Next, please. And this is the electrodecremental event seen in infantile seizures. Next, please. And this is an example of what's called secondary bilateral synchrony. And it's not the best example, but the best one I can find. This is an adult, left parasagittal, left temporal, right temporal. Notice the difference between the right temporal region and the left temporal region. Nothing wrong here. Everything is fine here. But notice these rhythmic waves with intermingled spikes on the right, all abnormal. And then suddenly that leads into this bilaterally synchronous discharge, a little higher voltage in the right as compared to the left, but very definitely bilateral. And then and so you have this focal onset of generalized spike waves here. And then also, unlike the usual generalized spike waves, there's a focal offset. So you go from a focal onset to generalized spike waves to a focal offset. Now, what's wrong with this slide is that the temporal origin for such bilaterally synchronous is less common than a frontal origin. Frontal origin is the most common origin for what's called secondary bilateral synchrony. Next, please. And that's terrible. Next. Yeah, well, that's a little better. Again, just to show how ubiquitous are slow spike waves. But what you have to always look for is any consistent focal onset so that you don't call something a Lennox-Gastaut syndrome when it actually is a focal lesion in one part of the brain, like the frontal lobe, becoming secondarily generalized. Next, please. And that's just more of the same. Next. Yeah. And here's a fairly decent example of secondary bilateral synchrony. And this is an ipsilateral ear reference, left side to the left ear, A1, right side to the right ear, A2. And in comparison to the left side, you can see these sequential discharges at FP2. Compared to the left side, you see them again, sequential discharges at F4. So that's focal right frontal becoming secondarily generalized. You can see the spike waves on both sides, focal again, and then secondary bilateral on both sides again. An excellent example, poor quality, but excellent physiological example of focally onsetting bilaterally synchronous discharges. And I don't know if there's anything focal in there. That's pretty diffuse. Next, please. Yeah. But just to show how abundant spike waves can be in both hemispheres nonstop. Next, please. Next, keep going. Yeah. Now, this is a curious thing. I'm not really sure what that's doing here because it's not very generalized. And but what you see here, this is very fascinating actually. Here is, it's got nothing to do with what I was just showing you, so we're all done with that. But this is an interesting EEG nonetheless. This is muscle activity here. And this is muscle activity here from frowning. Eh? From frowning, the fun, you know. Okay, but that isn't. That's a seizure. Totally different. So here's the background activity here. This is the left posterior head, and this is right posterior head. There's a little bit of a distinction between the left and the right. And in that there's more posterior slow of youth in the relatively normal left, and that's not present on the right. And then suddenly this looks just like muscle, but I think you can see that the individual discharges are a little bit more distinct than over here. But even more importantly, you have this start, this stop, and restart phenomena that you see in so many seizures, and then the evolution happening here. So here's muscle, but here's a seizure, and that's starting at P4, right parietal. Next, please. Oh, that's it. Well, thanks for your attention. Have a good trip home.